been a bit more of an unspoken issue in Duchenne, and as we are seeing more and more young men live longer and more healthy lives, dysphagia is becoming a lot more prevalent. So I'm going to focus in for the next 40 minutes on dysphagia care, using the right gear. Fab. Oh, no. Okay, so just so we're all on the same page, you may or may not have heard of the term dysphagia, and essentially it's a posh term for a disorder of swallowing. A normal swallow will allow you to eat and drink freely without any major complications. Now, in Duchenne, it's reasonably common more into the adult days for your swallowing to become more impaired, and the consequences of this can be fairly detrimental to quality of life and also living well and your consequential chest infections and nutrition. So when you hear the term dysphagia, it tends to refer to the whole system of getting food and drink from the hands to the mouth. It also refers to the bit that happens in the mouth and in the throat, which is the oropharyngeal phase of swallowing, and that's the bit we're going to focus in on a bit more today. And then once you've passed the food and drink from the mouth and the throat, it goes into the food pipe, and that's your esophageal phase. But for the purpose of today, we're going to focus in on the oropharyngeal aspects of the swallowing and the changes that can occur in Duchenne and what we can do to proactively identify and manage these problems to stop any detrimental consequences. So the pre-oral phase, usually my occupational therapy team colleagues would manage with our patients, because it's about getting the food and drink from the plate in front of you to your mouth. And as a speech and language therapist, I would focus in on the mouth and the throat aspects. And then my gastroenterology colleague would look into the esophageal phase, so they would look much more at any food pipe related issues and any stomach issues. So it really is a multidisciplinary team approach. So just to hone in on what are the issues in Duchenne and oropharyngeal dysphagia, so swallowing issues. Well, the primary issue is usually the weakness in the mouth and the pharynx. But also there are complications because of the respiratory changes as well. And the throat has two functions. So it functions to breathe and pass air into the lungs, but it also temporarily transitions into a food and drink way. And it's that chopping and changing of the throat's function that can cause issues. And if any of our patients have issues with their breathing, that can have a knock-on consequence to their swallowing as well. The other issues that we come across are anatomical, and it's fairly well known that young men with Duchenne can struggle with jaw opening, enlarged tongues and malocclusion, so jaw alignment, which from birth can cause problems with chewing and swallowing. The other issue, and again this is something that really isn't spoken about and hasn't really been looked at, are something we would describe as sensory deficits in Duchenne. So we talk a lot about the motor aspects and the weakness, but we don't always talk about changes in sensation. And we assume that if your swallowing is impaired, that you would identify those issues. But over time, because swallowing problems in Duchenne are fairly insidious, your body acclimatizes to those and you stop noticing the symptoms, and then things become what we describe as silent. So things occur and we don't notice them occurring until you see more significant consequences. So that's another one for us to be aware of. And usually for young men with Duchenne, certainly into adulthood, it's a mixture of all of the above that cause the issues. So in terms of the pathophysiology or the The muscles that are affected in swallowing, so the ones that I've underlined there for you, are the ones that are the big contributors in Duchenne. So at the top you've got orbicularis, so that's your lip muscles, and whilst there might be a little bit of weakness, it's not usually a significant problem in Duchenne type muscular dystrophy, which means that our young men can still use straws, they can still use SIP ventilators because their lip function's preserved. The biting and the chewing muscles are usually one of the earlier sets of muscles to show weakness, so prolonged chewing and longer meal times are fairly common signs and symptoms of early dysphagia and swallowing issues. The intrinsic and extrinsic muscles of the tongue, so the tongue is a huge ball of muscle which is super strong, and any weakness in the tongue can have quite substantial effects on not just chewing in the mouth but also passing food through the throat. Soft palate isn't usually a major problem, and young men with Duchenne don't often find problems with food and drink going back upwards into the back of the nose and causing sneezing and all sorts of issues. That's not usually an issue. But the muscles in the throat and the strap muscles in the neck do usually become weak, and the swallow function itself then becomes much weaker and food starts lodging in the throat. So that's the kind of muscle side of things, and the other interface here, like I said, is about respiratory failure, and some of the issues that come up again tailored to Duchenne are about breathing and swallowing coordination. So in a inverted commas normal swallow, the natural tendency would be to swallow and then breathe out, and that breath out after you swallow is a protective mechanism to keep things out of the airway. And what tends to happen in more advanced muscle disease is that people swallow and breathe in, and that breathing in pattern makes people more prone to breathing in food and drink residues. As you lose your lung volume, the pressures in your lungs drop, and the high pressure that you normally get in the lower part of the airway is protective as well for the swallowing. So if you have high pressure in the airway, it stops things going down the wrong way. If you have lower pressures and lower volumes, it means that your airway is less well protective if things were to go wrong, as well as your cough not being particularly powerful to cough things out. And the other thing is, it makes fairly normal sense that if you're struggling to breathe, you're going to struggle to swallow, because you're using the throat for the two things. And if you regularly have to stop and take breaths, your swallowing is going to become interrupted. And what we tend to see is a lot of our older men with Duchenne end up having to swallow in a piecemeal fashion. So they'll take a sip to drink and they'll swallow it 4 times, holding it in the mouth each time. And this is from a small service evaluation we did last year or the year before, where we looked at the sensory changes in the throat in Duchenne. And it was interesting to see that 1/3 of the young men that had X-ray swallow evaluations had food and drink going into the airway, and they weren't aware of that. So normally you would provoke some sort of cough response. And 7 out of 9, so quite a high proportion again, had food and drink left in the throat. And at that point they were telling me it was all gone, but you could still see those residues evident on X-ray. So I guess the big question is, how is this going to impact me, and what will be the problems for young men with Duchenne, with swallowing problems? Well, essentially the 2 major consequences of problems with swallowing are firstly weight loss, which can lead to dehydration and malnutrition, because you can't physically get enough in through the swallowing system to maintain your calories. The other side of that is our chest infections and pneumonia. So it can literally happen that food and drink goes down the wrong way. And the technical term, if you haven't already heard of it, is aspiration pneumonia. So that's pneumonia caused by food and drink going down the wrong hole. And naturally that causes unnecessary hospital admissions. And by trying to look and manage these things, what we're looking to do is lengthen life and improve quality of life by managing swallowing problems before they cause complications. And I guess in terms of the care recommendations now that have come out in 2018, it's been a real relief to me as a speech and language therapist working in this area that there's now been a shift in thinking, and it's a really important shift in thinking as far as I'm concerned, because prior to these care guidelines, dysphagia and swallowing issues weren't really considered to be pivotal in the Duchenne profile. They weren't talked about in huge amounts, and it's only now we have the luxury of working with and alongside all of our patients, certainly down at Queen Square, that we get to understand that actually dysphagia and swallowing problems are quite a big part of the adult profile in Duchenne, and it's great that we're now promoting much more advanced measures to detect it early. So, and the research that's out there already shows to us that it does increase in prevalence and severity as life goes on. So it is a big issue, and everyone's starting to recognise it. So I guess in the next half an hour or so, what I wanted to do was firstly to share the standards of care for dysphagia in Duchenne, but also provide some additional best practice guidelines for the identification and management of the swallowing problems. There aren't many clinicians who get the luxury of working alongside such a huge cohort of people with Duchenne. There aren't many speech therapists that do that, and we've certainly gleaned lots of information from doing that over the years. And also just give you some suggestions on self-advocacy and self-management for dysphagia in Duchenne. So I guess if we go back 8 years and look at the early guidance for swallowing examination, so these are the guidelines that were out 8 years ago. And these were the markers that we were asked to look for to identify whether there may or may not be some swallowing problems. So if anybody had lost weight of over 10% of their body weight, if meal times had crept up past 30 minutes, if there was fatigue, spilling, drooling, pocketing, persistent coughing, choking, gagging, wet voice, episodes of aspiration pneumonia or unexpected decline in pulmonary function, or a fever that was unexplained, or any other clinical indicators of dysphagia. Now, I don't know about you, but those symptoms seem pretty extreme. And if you're seeing those for the first time and we haven't managed the dysphagia before that, I would argue that you're catching it too late. The person has already started to begin to show signs and symptoms and possibly has already been in hospital with a chest infection. So that was the early guidance. Again, it was great that the guidance was in there though. So the new recommendations that came out this year do recommend a much more proactive approach, a much more anticipatory approach to the identification of swallowing problems, which is great because it means then we can optimise management before the problems start, maintain weight rather than wait for people to lose weight, aim to prevent malnutrition as a subsequent problem related to dysphagia, and reduce the risk of infection secondary to dysphagia. It also means that we can empower our patients to make much more proactive, informed decisions about their gastrostomies and enteral feeding, and ultimately improve health outcomes and quality of life. So you may not be able to see this slide, it's a bit tiny, but what I want to get the message across, and maybe this one will show it better, is that as a speech therapist, I see patients with a whole range of swallowing problems, and if you put Duchenne in that spectrum, Duchenne relatively, the swallowing problems, if you look at them on an x-ray, look relatively mild compared to some of my patients. But what the biggest issue is here, and one of the things that we have to do, is put those swallowing issues in context. So we put that swallowing issue in the context of a young man who has lost ambulation, a young man who no longer can feed himself independently, a young man who has problems potentially with the rest of the gastrointestinal system, and then the swallowing problems become more, the impact of the swallowing problems become more substantial because you're looking at it from a very complex viewpoint in the first place. So in terms of the updated guidelines, it's great to see that we're now recommending a much more anticipatory approach. And in 2010, the mention was that we start looking for swallowing problems in the late non-ambulatory phase. Now, 8 years on, we're now recommending that swallowing function is assessed in the early ambulatory phase. So that's quite a shift in timescales and thinking, and really great because it means that we can get in there early. The swallowing assessments and evaluations are repeated every 6 months, which is great. And the assessments are in the form initially of screening questions, which I'll give you a sample of in a couple of slides' time. There's also recommendations that gastrostomy, so feeding tubes, are discussed early when they're not needed, so that young men can make proactive decisions about whether they want to pursue gastrostomy early in the disease course or wait until they get symptoms. So in terms of the early identification, self-report or patient report is always the most accessible. Instrumentation, so x-rays, cameras in the nose, those sorts of things, are usually precious because they're hospital-based, they're difficult to get to, they're expensive, and largely inaccessible for a routine screening problem. But the problem is at the moment there aren't any robust existing self-report tools that we can reliably say, if you get this score on a report tool, then you must seek help from a speech and language therapist. But what we do know are what the symptoms are that we should be looking out for. And now we should be looking for them in the early ambulatory phase. So the tools that exist, and don't worry about all the extra words on this slide, but there's kind of 3 tools. The Sydney Swallowing Questionnaire is the one that I use in my clinic, and a colleague of mine validated it 3-4 years ago now for a cut-off score for Duchenne. And so they're looking for a score out of 1700, which may or may not indicate the presence of dysphagia. So that's the only tool at the moment that's been validated in Duchenne, but it hasn't been validated against anything instrumental, so it doesn't involve x-rays. So it's not a perfect study, but it's a start. There is another questionnaire called the MDT-PD, and actually it's a questionnaire that was designed for Parkinson's disease. But when you look at the content of that questionnaire, there's a big overlap of symptoms with symptoms that you would expect to see in Duchenne. And that's something that we found in a systematic review that we haven't managed to publish at the moment, but we'll get there. And we've also got a very quick nurse swallow screen that we use at Queen Square, which is designed on one that the Netherlands team have kindly shared with us, but we've tweaked it for our adult population. Again, it's not validated, but it's a tool in the absence of any others. So the Sydney Swallowing Questionnaire, there's a snapshot. It's a 17 question questionnaire, and there's a sample of questions 9 to 12. So it's a visual analogue scale, and that's a real nuisance at the moment because, of course, some of our young men who don't have upper limb function to write can't do that for themselves, so we're trying to get it electronic. But it does involve either a friend, family or carer just to track the pen along that line, and they shout stop at a point where they feel the symptoms sit on that scale. But the crudest way to look at it is just listing the symptoms that we would expect to see. So this is based on the systematic review that we've done. And these are the sorts of things that we would recommend, or I would recommend as a clinician, in looking for swallowing problems. So difficulties in chewing, difficulties clearing the mouth of food, slowed eating and prolonged meal times, needing to drink fluids with food to clear it away from the throat, a feeling of hard or effortful swallowing, food being more difficult than drink to swallow, a feeling an inability to swallow or just difficulties getting the swallow going, a feeling of food catching in the mouth, needing to swallow more than once each mouthful, a feeling of being unable to get food from the front to the back of the mouth, or symptoms of coughing, choking or throat clearing. So they're the sorts of things that we would ask our patients when they came into clinic. And it isn't good enough just to say, do you have any problems with swallowing? Because that isn't sensitive enough for anybody to say, yes, me. The other markers that are useful from a clinical point of view that we've noticed is that if any of our patients have lost their independence with feeding, are starting to require respiratory setup and ventilation, requiring cough assists, or are telling me that they're using their ventilation and cough assists during or immediately after meals, that's usually a red flag sign to me to have a little look and check the swallow function is still okay. It may just be a reassurance exercise at that point. So I guess the caveats as well from using patient report is that we recognise that in Duchenne there may or may not be some cognitive or learning disabilities. There may be some sensory changes, and the changes in the swallowing don't happen overnight. Just like the rest of the changes in Duchenne, it's really incremental and they're tiny changes, and that can affect how well our patients, certainly in clinic, will self-report, because people adapt really easily and normal becomes the new normal. So we always put consideration or encourage people to consider proxy reporting and the observations of the carers and the professionals that look after or care for or assist these young men. And a negative screen response shouldn't override basic clinical judgment. So if somebody comes back and repeatedly says no to all of those questions, but there are clear signs or clinical markers that there may be swallowing problems, then of course we'd still investigate if the patient was happy for us to do that. And there is the opportunity now for specialist teams to introduce adjunctive measures. So there's a new timed test of chewing, which is a fun task to do. So essentially they're timing how long it takes to chew a certain material to see whether there's a cut-off for that being, or there's a cut-off there to indicate new chewing problems. So I guess speech and language therapy assessment, and again, just in case anybody here is not clear, that speech and language therapy title is hugely misleading. And in neuromuscular disease, our focus is often in dysphagia and swallowing, and we tend not to do a lot of classic speech therapy. But in our speech therapy assessment, which is basically a clinical swallowing assessment, you would expect a clinician to be taking a very comprehensive case history. You'd also expect a clinician to have working relationships, so a speech therapist to have working relationships with the respiratory physician, a nutritionist and a dietitian, and be placing their dysphagia in the context of the patient themselves. And the clinical bedside assessment is essentially a clinician working from the outside. We're not doing any invasive tests at that point, and our clinical assessment can always miss problems, and the problems in Duchenne are subtle. And so I spend a lot of time working with speech therapists who aren't familiar with Duchenne to explain that actually you might not see a huge amount of problems just looking and watching the patient. And so we always recommend that anybody doing a clinical assessment should at least spend the meal time with the patient, because usually that will increase your chances of spotting the problem. A kind of whistle-stop swallowing assessment with a glass of water and a biscuit is not usually adequate enough. So we're starting to develop assessment proforma for speech therapists who don't routinely work in neuromuscular centres, just so we are confident that everybody knows what they're looking for, and that we are ticking off all those essential domains that are specific to Duchenne, nutrition and swallowing issues. And I think it's fair to say that a lot of our patients, or some of our patients, aren't known to speech therapists before they arrive in the acute hospital with a chest infection. And an admission to hospital with a chest infection is enough to warrant a referral to a speech and language therapist. And at that point, there should be some sort of consideration for an instrumental assessment, so an X-ray or a nasendoscopy, particularly if the physician is saying, is unclear on what the ultimate cause of the chest infection was. So aspiration pneumonia is a possibility. And we have to be aware as well that if our patients are in hospital, that there might be an acute drop in swallowing function. So it might not look so good as it is normally because our patient is unwell. So it should be reevaluated after they've been treated and are back home and well again. So the instrumentation side of things that you've heard me talk about should be considered as part of a very comprehensive swallowing assessment, because it can help us to understand and tailor management, and it gives our patients biofeedback to make informed decisions about their swallowing. It can detect sensory changes that you can't see from the outside. But ultimately, before we put people through these assessments, we always need to ask whether it's going to change what we do at that point or at any point in future. So the two types of instrumentation that you would expect to see used at some point in the dysphagia journey are a video fluoroscopy, which is that one on the left-hand side, which is an X-ray study of the swallowing, and or a nasendoscopy. So that's on the right-hand side. It's a little bit, that picture's a bit dated now, so we usually have a big machine rather than a physician looking through a scope through the eye. But it's essentially a tiny scope that goes in the nose and looks downwards. It gets a bird's eye view of your throat and your airway. So they are two of the swallowing assessments that we would have routine access to. And there's probably no prizes for guessing which one most of our patients go for. It's the X-ray, because it's not invasive. And when you often offer patients an opportunity to have a camera up their nose, they usually get told to go away in no uncertain terms. But these are the sorts of changes that we might see on those assessments. So you can see on the X-ray study over there, and on this one, that there is a black collection there, which is essentially food and drink holding up in the throat. And then on the one, the nasendoscopy here, that yellow patch just on the left-hand side is a little bit of banana, which is left over in the throat. It's just on the left-hand side of the airway, so the glottis that you can see in the middle of the picture, that dark black hole. And that's the sort of pictures that are fairly common for us to see as clinicians. So we would be looking at whether the patient can feel that leftover, whether the patient can clear that leftover, whether that leftover ends up ultimately being inhaled into the airway. So we watch for patterns to assess risk, so we can then determine the best management plan. So if we detect a swallowing problem, what do we do about it? And that's the big question, isn't it? And there isn't a lot out there at the moment that guides us, but there's enough clinical experience for me to be able to tell you that this is how we would routinely manage a patient with Duchenne and dysphagia. So our first line management is to get all of these people together and have a conversation. So the speech and language therapist will trial certain approaches, which I'll show you in a moment. But importantly, or as importantly, if not more importantly, the dietitian should be involved, and probably should be involved, should definitely be involved before the speech and language therapist, because of weight and nutrition issues earlier on in the childhood. So the dietitian should be there to optimise oral intake and calorific intake if there is a problem with swallowing. And the physiotherapist, who I referred earlier as my wingman, is there because your physiotherapist will be there to try and optimise airway clearance. So if we know that food and drink is going down the wrong way, we would turn to our physiotherapist and make sure that there is a robust chest management plan in place. So mechanisms in place for cough augmentation and to keep that airway as clear as we can. And our respiratory physician would also be involved alongside a neurologist, because we would be looking at ways to make sure, or checking, that our patient is optimised from a ventilation perspective. Because if the swallowing issues are worsened by the respiratory fatigue and the respiratory effort, sometimes you can see if you optimise the respiratory problems, you get a little bit of improvement or a better management of the swallowing side of things. So first line, we would do all of those things as a team. And then as part of the first line management, we would have conversations early, and if we hadn't already had them before, we would have conversations with our patients about gastrostomy, and we would talk to our gastroenterologist and our anaesthetist about risk factors and assessment for gastrostomies and feeding tubes. As part of the first line management, we might not get to the point where we use a gastrostomy or a feeding tube, but at least we're having those discussions. The treatment options from a direct swallowing point of view, so what would a speech therapist do, or what would you expect a speech therapist to be thinking about? Well, there's enough literature at the moment to suggest that compensation for the swallowing problems are to some point effective. So we understand the impairment, there's enough studies on what's causing the problems to know that if we start modifying the food to softer, more moist or liquid foods, it eases the swallowing problem and allows our patients to get more calories in more freely and reduces the amount of residue in the throat. Fluid washes is another compensation that a lot of our patients use, so they sip between their mouthfuls of food to clear the throat. We get a lot of questions about, can we treat the swallowing, can we exercise the swallowing, and a team over in the Netherlands had a little look at that not so long ago, and they tried a very small study of chewing gum to see whether using chewing gum on a proforma basis improved chewing strength. And that actually found, probably not surprisingly, that chewing gum didn't improve strength, but what it did do is help tailor chewing skill. So they're looking at improving skill rather than increasing strength. And there's, again, this is something we experience clinically, but they've also started looking at whether swallowing improves when you optimise ventilation. So there have been a couple of studies on people swallowing on and off ventilation, and there's early suggestions that actually optimising ventilation or swallowing on ventilation may improve the swallowing function on certain parameters. In Duchenne, but I think this is really early evidence, and it's enough evidence to make us think as clinicians and patients to ask those questions: if I did this, will it help? And it would allow us to clinically explore whether that is going to help or not. So that's kind of what we would be offering or discussing at the point of identifying swallowing problems. And the second line management, if none of that worked, and I have to say for a lot of people, if you get the right multidisciplinary intervention, you can stabilise the problems and you can manage the weight loss. But if that isn't sufficient, and sometimes it isn't, then we start talking about second line management, and that's offered with full multidisciplinary team support, and that's the gastrostomy, so the small tube that you get popped into the tummy, which sits under the t-shirt, and you wouldn't know it was there. And that allows the swallowing mechanism to be bypassed. And calories can be popped in on a flexible basis to get the calories in, and you can, as long as the swallowing problems aren't causing infections and pneumonia, you can still eat and drink with a gastrostomy, and that's something that often some of our patients don't realise they can do, so it's not mutually exclusive. But I think at the moment it's fair to say that there is no common pathway for our patients with Duchenne. Certainly in my clinical experience, we have seen young men at transition come to our clinic who have already been diagnosed with swallowing problems, and they may have come to us essentially nil by mouth and having full gastrostomy intake. On the other end of that kind of wide spectrum, we see older men who are eating and drinking soft foods, drinking normally, and considering maybe a gastrostomy just to get some extra calories in because their weight is low. And we also see people come to our clinic who have learnt or taught themselves to eat and drink on ventilation. So there isn't one recipe that fits. And I guess then, if we are doing lots of assessment, lots of screening, and we don't identify any swallowing problems, I think it's the routine monitoring that the new care guidelines highlight for us. So every 6 months we should be looking or repeating swallowing screening, and that might be by using a tool, it might be just by asking some of those questions or being mindful of those questions that are highlighted before. And they should always be reassessed from my personal point of view in the context of changes in respiratory function, cough function, and then mobility as well, because these swallowing changes, of course, aren't occurring in isolation. And we have to look hard. We have to look hard as clinicians, carers, parents, and patients to look for the changes, because we adapt so easily to them and we don't realise how much things are changing. And the question about, I always ask my patients to reflect back a year, so go back to last Christmas and think about your Christmas meal and how does that look different to you now. And then we would always consider instrumentation, repeating instrumentation and x-rays as we see fit, but we don't do it just because. So from a patient education point of view, there's enough things out there to be fairly clear that certain things can work as a kind of proactive management. The first patient education advice, first advice we give to our patients is don't ignore the symptoms, because we might be able to do something about it. And remember that the changes are slow, and reflecting back 12 months to assess if anything has changed is usually a useful thing to do. Again, this sounds like very simple advice, but it works. So taking care to chew food down well. So if the chewing muscles have weakened, there may or may not be a tendency to swallow food that hasn't been well chewed, and then that food will then get stuck. So not being rushed through a meal, and that's really important if you are now relying on someone else to assist you with feeding, because you're being fed at somebody else's rate. So take control of your own meal times. Avoid or adapt tricky or really difficult foods. If it's really difficult, you don't eat it, or you think about how you can modify it. Consider starting to move towards blended or liquid foods. It may not be all the time, but it might be when you're feeling fatigued, when you're unwell with a cold. Adapt the food and be flexible. You can work flexibly with this. Some of our patients maybe have a blended meal in the evening when you're fatigued from a respiratory point of view, and have a more normal breakfast in the morning. Small and regular sips of fluids when eating can help to clear the throat. Again, we tend to recommend that on a patient-by-patient basis. One thing that most of my patients say doesn't help is that when they eat a full meal and then they drink a whole pint of water, because then all sorts of things go wrong. So we recommend often just sipping through the meal. Avoid talking whilst eating, because you're then using your throat for two functions, breathing and swallowing, and that never goes down well. Trying to sit upright during and after your meal, again, it's basic advice, but it's surprising how many bad habits we get into. Allowing yourself plenty of time and instructing people who are assisting you with how they can support you best, so you stay in control. The other thing is that I would certainly recommend is try to avoid using a cough assist and ventilation immediately after a meal. And that's because the positive pressure can push things around in your throat. And if you've got things sat there and you're blowing air in, then you're putting yourself at more risk if you do have things there. If people come to me and they are having to use a cough assist and ventilation straight after a meal, that's usually a red flag sign for me to investigate further. And know who to contact if things aren't right. And I guess the other thing to say that I've alluded to is that as speech therapists, we are based all over in all different settings, and not everybody has the luxury, like I do, of working in a neuromuscular care centre. So the clinicians working in dysphagia understand dysphagia well, the speech therapists, but they may not work with neuromuscular disease as on a regular basis. So we would encourage clinicians to liaise with centres, neuromuscular centres, to find out what the latest evidence base is and seek advice if they're not so sure, and try to keep up to date with what's going on in the literature. And that's why we encourage our own patients to advocate for themselves on this side, because not all AHPs have the luxury, like I do, of working only with Duchenne and certain muscle conditions. So your dysphagia care, if you're thinking about your care standards and your swallowing changes, your dysphagia care at the very least should be proactive, preventative and focused in a multidisciplinary team. We're aiming to guard against malnutrition and prevent hospital admissions with pneumonia caused by food and drink going down the wrong way. It should be realistic. And ultimately promote independence and quality of life. And be totally centred around patient choice with the full support of a skilled MDT. So most of our patients, all of our patients, in fact, and their families, make their own decisions, and we as a team will feed into all the options available. And those decisions and outcomes change over time. So as a summary, as of this year, in the clinical care recommendations, we are recommending routine, early, proactive screening for dysphagia with a low threshold of concern and an onwards referral to a speech and language therapist. And this should be starting now in the early ambulatory phase, and that's pretty early on, that's before transition. We're encouraging advanced, open decisions about feeding and nutrition with the patient and the family. And speech and language therapy assessment, again, this is my own opinion, it should be based as a wider MDT, or at the very least, liaise across multidisciplinary teams, because you can't manage dysphagia in isolation. We should have a fairly low threshold for any instrumental examination, so x-rays and nasendoscopy, if we're concerned that there is an underlying problem. And have established links with specialist centres and neuromuscular care centres. And the clinicians, of course, should be up to date with the latest research and treatment options. And actually, that's why we encourage our patients and families to be up to date, because then you can share what the best practice should be. And thank you very much for listening, and happy to take any questions. I would say if there's undigested food in there, there's a chance that food is sitting around in the throat. So that should be examined to start with, either with an x-ray or a nasendoscopy. But also what we haven't touched on today is the link with gastroenterology. So there may be issues in the upper digestive tract that may be reflux related or slow peristalsis. So on those sorts of symptoms, I would be asking the gastroenterology team to give an opinion as well. I don't know whether that's the case for you. It can be 2 hours delayed after a meal. Sometimes it's a later problem in the gastro system. And if he's on ventilation as well, there's an interface there that might be problematic. So it would require, again, the whole lot to be pieced together. Great. I think that's it. So thank you very much, guys.